This is part 6B of my masterclass on anemia during pregnancy, where I will discuss iron studies which are done to confirm iron deficiency anemia. In the concluding part of investigations, I will also give an overview of other investigations done for a case of anemia during pregnancy. The subsequent investigations conducted when iron deficiency anemia is suspected entail the execution of tests to ascertain the body's iron status. These tests are sometimes referred to as ferrokinetic studies. The term ferrokinetic pertains to a methodology employed for measuring iron levels within the body, encompassing iron exchange, turnover, and utilization. Following iron studies are conducted to ascertain the potential causes of iron deficiency in various types of anemia. These include serum iron, total iron binding capacity, percentage saturation, serum ferritin, soluble transferrin receptor assay, and free erythrocyte protoporphyrin FEP. Prior to the availability of serum ferritin, bone marrow examination was the sole available investigation for measuring iron stores in the body. I will provide an in-depth discussion of each of these studies. Iron studies must be performed in fasting state as serum iron transferrin saturation can increase within 4 hours of consuming an iron-rich meal. Serum iron is a measure of the amount of iron that is freely circulating in the blood and bound to transferrin. Serum iron is decreased in iron deficiency anemia and anemia of chronic disease. It is increased in iron overload conditions such as hemochromatosis and sideroblastic anemia. Remember, serum iron is not an investigation that is specific for iron deficiency anemia. While low serum iron is a strong indicator of iron deficiency, it can also be affected by other conditions such as chronic disease or inflammation. Therefore, serum iron tests must be used in conjunction with other tests such as serum ferritin and transferrin saturation to provide a more comprehensive assessment of iron status. The normal range for serum iron level is typically between 60 to 170 micrograms per deciliter for men and 50 to 170 micrograms per deciliter for women. Next, I will discuss TIBC. First, some basics. As described during the segment on iron metabolism, iron that is absorbed from GI tract and also the iron released from senescent RBCs that are destroyed by the reticuloendothelial system like spleen and stored in macrophages circulates in plasma bound to a transport protein called transferrin. This is then transported to bone marrow where ferric iron is used for erythropoiesis. To understand this, I would like to give an analogy of a transport truck full of boxes. As shown, raw material from two stores is loaded into the boxes, which are put on a truck which takes it to the manufacturing factory where it is unloaded. Here, the GI tract and the macrophages in the spleen are the raw material stores. Transferrin is the box where raw material, which is iron, is stored, and bone marrow is the manufacturing factory. Measuring the total number of boxes in the trucks is called TIBC. Remember, as explained earlier, iron cannot be carried by itself. It must be stored in boxes. To extend this analogy further, all the boxes are not full of iron. Some boxes are empty and capable of carrying more iron. Thus, the number of boxes full of iron divided by the total number of boxes multiplied by 100 gives the percentage iron saturation. TIBC is basically transferrin level, which is beta-1 globulin that carries ferric iron in blood. Remember, TIBC is increased in only two conditions: iron deficiency anemia and pregnancy. There is an inverse relationship between stored iron, that is ferritin, and transport iron, that is transferrin. So, when ferritin decreases, as in iron deficiency anemia, transferrin increases, that is TIBC increases. Elevated TIBC combined with low serum iron and ferritin level supports the diagnosis of iron deficiency anemia. Furthermore, a pregnant thalassemia minor patient whose TIBC is high will require iron therapy. Similarly, a patient of chronic disease who has low serum iron and high TIBC also requires iron therapy. The cutoff level for TIBC is 450 micrograms per deciliter, which is a pathognomic finding in iron deficiency anemia. In summary, remember TIBC is just one aspect of iron metabolism and one piece of the diagnostic puzzle. Transferrin saturation (TSAT) is a laboratory value expressed as a percentage indicating how much iron is bound to transport protein transferrin. It is calculated by dividing serum iron by total iron binding capacity (TIBC) and the result is typically expressed as a percentage. For example, if a pregnant female patient's serum iron level is 100 and TIBC is 300, then the percentage iron saturation is 33%. Please remember, any amount of iron in ingested food can affect serum iron levels, and therefore overnight fasting is required for measuring percentage iron saturation. TSAT is decreased in iron deficiency anemia and increased in iron overload. The normal transferrin saturation range is generally considered to be between 20 to 50% for females. Transferrin saturation less than 20% is diagnostic of iron deficiency anemia regardless of serum ferritin level. There is one more important investigation in iron studies. Cellular iron uptake is mediated by a specific receptor for transferrin called transferrin receptor. Soluble transferrin receptor assay (STFR) is a blood test that measures the level of soluble transferrin receptors in the blood. Soluble transferrin receptors are proteins found in the blood that are cleaved from the membrane-bound transferrin receptors found on nearly all cells. These receptors play a crucial role in iron uptake and their levels can indicate the body's iron status, particularly in cases of iron deficiency anemia. Serum concentration of these receptors reflects erythropoietic activity. Soluble transferrin receptor assay is now widely available all over the country. It is extremely important because it is the test to differentiate between iron deficiency anemia and anemia of chronic disease. Unlike ferritin, STFR is not affected by interleukin 6. Concentration of soluble transferrin receptors is increased in iron deficiency anemia. On the contrary, it is normal or low in anemia of chronic diseases such as tuberculosis, arthritis, ulcerative colitis, cancer, etc. It is also worth noticing that when value of most investigations for anemia decrease, STFR assay is one lab value that increases in iron deficiency anemia. In the subsequent slides, I will address the most critical investigation that regrettably is frequently overlooked by clinicians. It is serum ferritin test. Many believe that measuring serum iron is sufficient as iron and ferritin are similar tests. However, they are not identical. In the earlier segments, I advocated for defining iron deficiency anemia based on serum ferritin levels rather than hemoglobin levels. You may question the necessity of this expensive test. Now I will present my argument. Firstly, serum ferritin provides insights into the iron stores in the body, whereas hemoglobin cannot. Secondly, it is the first iron marker that becomes abnormal in iron deficiency anemia and in iron deficiency disease. Thirdly, it is the only investigation that can diagnose iron deficiency disease. It is therefore unfortunate that serum ferritin is not performed routinely. In a patient suspected to have anemia during pregnancy, serum ferritin level must be checked at least once after the first trimester. I will start with basics. The history of ferritin, an ancient and versatile protein, began with a discovery by the Czech scientist Wilhelm Lofberger, who in 1937 named ferritin an iron-rich compound obtained via the crystallization of horse spleen extract. Ferritin is composed of 24 subunits that form an almost spherical shell, delimiting a cavity where thousands of iron atoms can be stored in a non-toxic ferric form, thereby preventing cytosolic iron from catalyzing oxidative stress. Ferritin, a ubiquitous iron storage protein, exists as heteropolymers composed of varying ratios of two main isoforms, heavy, that is H, and light, that is L subunits. H-rich ferritin is prevalent in tissues with high iron turnover like the brain and heart and possesses peroxidase activity, that is oxidizing iron. L-rich ferritin found in iron storage organs such as the liver and spleen lacks peroxidase activity and plays a role in iron nucleation. For diagnosis of iron deficiency anemia or estimation of iron stores, L-rich subunit is measured. Ferritin is a storage protein that keeps iron in a bound non-toxic form. Ferritin is produced in liver and especially bone marrow where it supplies iron for erythropoiesis. A ferritin level of 1 microgram per liter corresponds to approximately 8 milligrams of stored iron per kilogram body weight. Keep in mind that this is an estimate and may not be exact for every individual. However, it is a useful guideline for clinicians to assess iron stores and guide treatment decisions. Ferritin is degraded by lysosomes into hemosiderin. Ferritin levels are depleted in iron deficiency anemia and iron deficiency disease. They are increased in iron overload and anemia of chronic disease. One drawback of ferritin is that it is also an inflammation marker. In presence of inflammation, it is made in greater quantities due to interleukin 6, IL-6. Ferritin is an acute phase reactant and goes up with inflammation or infection. It is also known to rise during first trimester of pregnancy. There are two takeaway messages from this. One, while low ferritin is absolutely diagnostic of iron deficiency anemia or iron deficiency disease, normal or high ferritin does not rule out iron deficiency. 2. In pregnant patients, serum ferritin as a marker should be estimated after the first trimester is completed. It must be noted that 50% of non-anemic pregnant women, that is those with normal hemoglobin, have low ferritin levels. This is called iron deficiency disease. They require extra iron supplementation during pregnancy and after delivery. I will now discuss the practical aspect, that is diagnostic thresholds for iron deficiency anemia during pregnancy. Different professional organizations recommend varying thresholds. WHO says serum ferritin less than 15 micrograms per liter, remember not deciliter but liter, for the first trimester only as an indicator for iron deficiency anemia or disease, with no specific recommendations for second and third trimester thresholds. CDC recommends a level less than or equal to 15 micrograms per liter for all trimesters. ACOG talks about a ferritin level less than 30 micrograms per liter in any trimester as a diagnostic threshold. ACOG's higher threshold, that is less than 30 micrograms per liter, provides better sensitivity, that is 92%, without significantly compromising specificity, which is 98%. However, as per physiologically based analysis, I recommend thresholds of less than 25 micrograms per liter for first trimester and less than 20 micrograms per liter for second and third trimesters. Research indicates ferritin levels less than or equal to 50 micrograms per liter may represent early iron deficiency, highlighting the need to consider intervention, that is replenishing iron stores before severe depletion occurs. To summarize, primarily L-rich ferritin isoform levels less than 30 micrograms per liter indicate iron deficiency, while greater than 300 micrograms per liter suggests overload. Remember, serum ferritin levels are measured using radioimmunoassay. First, some basics. Under normal physiological conditions, iron is incorporated into protoporphyrin 9 by ferrochelatase enzyme, also known as heme synthetase enzyme, to form heme, which subsequently combines with globin to produce hemoglobin. Free erythrocyte protoporphyrin FEP and its related compound zinc protoporphyrin ZPP, which can be measured easily, represents critical biomarkers in the early detection and assessment of iron deficiency anemia. These compounds accumulate in red blood cells whenever insufficient iron is available for heme synthesis, providing clinicians with an early indicator of iron deficient erythropoiesis. It takes 2 to 3 weeks to become abnormal once iron stores are depleted. It can be evaluated by a lab test called zinc protoporphyrin ZPP. A zinc protoporphyrin to hemoglobin ratio greater than 80 micromoles per mole is generally considered indicative of iron deficient erythropoiesis. Elevated FEP levels, that is greater than 70 to 100 micrograms per deciliter, suggests iron deficiency anemia. FEP measurement offers unique advantages in early detection and population screening applications. FEP levels may not be increased in mild or early iron deficiency. FEP can, however, distinguish iron deficiency from alpha thalassemia as its level is normal in alpha thalassemia. There are a few compounding factors that must be taken into consideration when using FEP as a diagnostic test. FEP levels do not rule out iron deficiency entirely, as FEP can be influenced by other conditions. When high ZPP to hemoglobin ratio occurs with elevated ferritin concentration, that is greater than 200 micrograms per liter, this pattern suggests severe inflammatory blockade or anemia of chronic disease or other causes of impaired iron utilization rather than iron deficiency. Lead poisoning and erythropoietic protoporphyria represent other important compounding factors. Lead exposure interferes with ferrochelatase activity, leading to increased metal-free protoporphyrin production and subsequent ZPP elevation. Bone marrow aspirate is stained with iron stain called Prussian blue, which stains iron granules blue, a phenomenon known as Pearl's reaction. This technique aids in determining iron stores in bone marrow. Blue stained RBC precursors are iron containing cells called hemosideroblasts. Under a microscope, the percentage of hemosideroblasts is calculated. If the percentage of hemosideroblasts is greater than 20%, iron stores are considered adequate. Conversely, if the percentage is less than 10%, it indicates poor iron stores. Percentage between 10 to 20% is considered equivocal. Due to its invasive nature and the availability of other tests such as ferritin levels, bone marrow studies have now become obsolete. Having completed a thorough analysis of diverse iron-related studies, I will now concentrate on other diagnostic tests conducted during pregnancy to determine the cause of anemia. Instead of bone marrow biopsy, which is a very painful and invasive procedure, one can perform a simple therapeutic test for diagnosis of iron deficiency anemia. The patient is given oral iron. If hemoglobin improves, it is iron deficiency anemia. Key components of the therapeutic test are as follows. Administrative protocol. Typically, 100 to 200 milligrams of elemental iron in the form of ferrous sulfate 325 milligrams 1 to 3 times daily is given by oral route. Duration of treatment is 4 to 6 weeks. Hemoglobin levels and reticulocyte counts are checked at 1 to 2 week intervals for detection of early response. A hemoglobin rise of greater than or equal to 1 grams per deciliter within 1 month confirms iron deficiency anemia. Another indicator of early response is reticulocyte surge. If the retic count peaks within 7 to 10 days of oral iron, it indicates positive response. However, ferritin normalization takes a long time. It is expected within 3 to 6 months of sustained therapy. Failure criteria are suboptimal response. This warrants investigation for non-compliance or improper dosing. Concurrent inflammation or infection, which is indicated by a CRP greater than 5 milligrams per liter. Malabsorption, for example, celiac disease, H. pylori infection, etc. Occult blood loss, for example, because of GI malignancy. Clinical utilities of therapeutic tests are as follows. Diagnostic confirmation. It distinguishes iron deficiency anemia from anemia of chronic disease when ferritin levels are equivocal, that is 3200 nanograms per liter. Cost effectiveness. It avoids invasive tests such as bone marrow biopsy in straightforward cases. Therapeutic guidance. Rapid responders may be transitioned to lower maintenance doses. Non-responders may require intravenous ions, for example, ferric carboxymaltose or advanced workup. This test has some limitations. False negatives occur in 30 to 50% of patients due to poor absorption or compliance issues. Delayed confirmation. Therapeutic test requires weeks for definitive results compared to immediate lab tests. There is one major advantage of doing different iron studies, which I have just described. Based on the results, one can stage the patients into four groups. The progression of storage iron deficiency occurs through four distinct pathophysiological stages illustrated in these diagrams, each marked by specific laboratory and clinical findings. Stage 0 represents normal iron homeostasis characterized by adequate iron stores, that is, ferritin greater than 13 micrograms per liter, normal serum iron, that is between 75 to 150 micrograms per deciliter, and unimpaired hemoglobin synthesis, that is hemoglobin greater than 12 grams per deciliter in women. Transferrin saturation remains within 20 to 50%, reflecting balanced iron availability for erythropoiesis and systemic needs. Stage 1, also called depleted iron stores, begins when iron losses exceed intake, leading to bone marrow iron store depletion, characterized by serum ferritin less than 13 micrograms per liter. As a consequence, compensatory mechanisms increase intestinal iron absorption and transferrin production, elevating total iron binding capacity while serum iron and hemoglobin remain normal. This latent phase often goes undetected clinically but signals heightened risk for progression. Stage 2, called iron deficient erythropoiesis, emerges when insufficient iron reaches erythroid precursors, reducing serum iron, which becomes less than 50 micrograms per deciliter, and transferrin saturation less than 15%. Erythrocyte protoporphyrin accumulates as zinc substitutes for iron in heme synthesis, elevating free erythrocyte protoporphyrin (FEP) and soluble transferrin receptors. STFR becomes greater than 8.5 milligrams per liter. Though hemoglobin may remain normal initially, reticulocyte production declines and early microcytosis, that is MCV less than 80 femtoliters, becomes detectable. Stages 1 and 2 are referred to as subclinical anemias as hemoglobin is normal and patient is asymptomatic. Stage 3 is called overt iron deficiency anemia, which manifests when hemoglobin falls below gender specific thresholds alongside marked microcytosis, that is MCV less than 76 femtoliters, and hyperchromia, that is MCH less than 27 picograms. Red cell distribution width RDW increases to greater than 15% due to heterogeneous cell sizes. Ferritin plummets to less than 15 micrograms per liter, while TIBC peaks at greater than 450 micrograms per deciliter. Clinical symptoms such as fatigue, pallor, and exertional dyspnea emerge as tissue oxygenation falters. Without intervention, severe cases will develop koilonychia, pica, and impaired thermoregulation, which are signs of tissue iron deficiency. This is another diagram that illustrates progressive spectrum of iron deficiency. The top left diagram shows normal state where not only hemoglobin but also iron status are full. This is normal stage. In the two in between stages, there is deficiency of iron stores, but hemoglobin is still normal. These are called as subclinical anemias. The group on extreme right shows frank iron deficiency anemia, where stores are totally depleted, that is, marrow iron is absent, serum ferritin is low, serum iron is low, transferrin saturation is low, and hemoglobin goes down with red blood cells being hyperchromic and microcytic. It is important that a clinician must diagnose iron deficiency disease at stage 1, that is the stage of iron store depletion, where RBC morphology is normal, hemoglobin and transferrin saturation and serum iron are all okay. The only thing abnormal is serum ferritin or marrow iron. This highlights the importance of estimating serum ferritin level at least once after the first trimester of pregnancy. This table summarizes the findings of ferrokinetic investigations in different types of anemias, as well as what happens to them in iron overload situation. You can pause the video here to assimilate the information. This busy slide shows the newer markers for diagnosis of iron depletion and overload. They are marked with asterisks, for example, zinc protoporphyrin, hepcidin, inflammatory markers, and ferritin bound iron. These are not available to clinicians. Hence, I will skip them except for one that is important for understanding the basics, and that is hepcidin serves as a critical biomarker for diagnosing iron deficiency anemia by directly reflecting systemic iron availability and regulatory mechanisms. Hepcidin levels decline proportionally with iron store depletion. Unlike ferritin, which is confounded by inflammation or transferrin saturation, that is reflected by recent dietary intake. Hepcidin levels are low in iron deficiency anemia but elevated in anemia of chronic disease due to interleukin 6 driven upregulation during inflammation. In cases with an inflammatory component and elevated hepcidin, oral iron may be ineffective. Hepcidin levels can help physicians decide if intravenous iron, which bypasses intestinal absorption regulated by hepcidin, might be a more appropriate initial or subsequent therapy. For diagnosing true iron deficiency anemia, hepcidin levels are typically expected to be low, often cited as less than 10 to 20 nanograms per ml. Some studies suggest cutoffs like less than 14.5 nanograms per ml or less than 20 nanograms per ml have good sensitivity and specificity for distinguishing IDA from ACD. Integrating hepcidin with ferritin and interleukin 6 measurements enhances diagnostic precision, particularly in complex cases like chronic kidney disease or pregnancy related anemias. However, standardized assays for hepcidin quantification remain under development, though ELISA based methods show promise. Crucially, hepcidin levels should not be interpreted in isolation. They must be considered alongside a complete iron panel, for example, serum iron, ferritin, transferrin saturation, TIBC, etc., inflammatory markers like C-reactive protein and ESR, and the overall clinical picture of the patient. Once again, this table summarizes the hematological parameters in iron deficiency anemia, indicating normal range and their threshold for diagnosis of iron deficiency anemia. Serum ferritin is an important biomarker. In my previous discussions on anemia diagnosis, I understand that some of you may be experiencing confusion or difficulty recalling the various investigations. To alleviate this, I would like to present a concise summary of the key indices for diagnosing iron deficiency anemia that you should remember. Hemoglobin less than 10 grams per deciliter. This is sign of iron deficiency anemia. Serum ferritin less than 15 nanograms per ml or 15 micrograms per liter. This is diagnostic criteria for iron deficiency disease and iron deficiency anemia. The normal range for serum ferritin is 50 to 100 micrograms per liter. Transferrin saturation less than 20%. This is diagnostic criteria for chronic iron deficiency anemia regardless of serum ferritin levels. The normal range for transferrin saturation is 25 to 35%. I call this the 10-15-20 rule. 10 is hemoglobin, 15 is ferritin, and 20 is TSAT. Got it? Have you heard of Menser index? It is the quotient of MCV to RBC count. This index is used to differentiate between iron deficiency anemia and thalassemia. If it is greater than 13, the diagnosis is iron deficiency anemia. If it is less than 13, it points to a diagnosis of thalassemia. This is because in thalassemia, the RBC count is normal or increased, the cause for which is not known. Reticulocyte count is a window of the bone marrow. Normally, reticulocytes mature in the peripheral blood for about 1 day before becoming mature red blood cells. In response to anemia, the bone marrow releases them earlier, and these shift reticulocytes take longer to mature in the blood. That is about 2 to 3 days. The normal reticulocyte count is 0.5 to 2.5%. A retic count greater than 4% is considered increased. A simple reticulocyte count can be misleadingly high in anemia. Hence, other indices such as reticulocyte maturation index (RMI) and reticulocyte production index (RPI), which are corrected values, are used in hematology. These give a more accurate picture of the rate of effective red blood cell production. Reticulocyte maturation index is calculated by measured hematocrit divided by normal hematocrit. For example, if measured hematocrit is 45, which is also the normal hematocrit value, then the maturation index is 1. In iron deficiency anemia, the reticulocyte count and reticulocyte maturation index are normal. After iron therapy, however, reticulocyte count increases. A reticulocyte production index of less than 2 in an anemic patient generally suggests an inadequate bone marrow response, while a reticulocyte production index of greater than 3 suggests an appropriate response. This picture is a supravital stain of a peripheral blood smear that shows blue stained residual reticulin, that is ribosomal RNA, in red blood cells, which are called reticulocytes. Other investigations done to determine the etiology of anemia are urine routine and microscopic, and sometimes urine culture to rule out urinary tract infection, stool examination for cysts, ova, ocal blood or steatorrhea, X-ray chest to rule out pulmonary tuberculosis, which is an important cause of anemia in India, BUN and serum creatinine as a part of kidney function, serum folate levels, serum Figlu levels, and serum B12 levels to rule out megaloblastic anemia. Here is a list of investigations that must be done to detect other etiologies of anemias. Coombs test, direct or indirect test, osmotic fragility test for detection of congenital spherocytosis, hemoglobin electrophoresis for diagnosis of thalassemias, sickling test for sickle cell anemia, serum bilirubin for hemolytic anemias, G6PD assay for detection of G6PD deficiency, and estimation of fetal hemoglobin HbF for thalassemia. Since severe long-standing anemia can also affect fetal growth and development, investigations such as serial fetal growth ultrasound scans must also be done to rule out fetal growth restriction. These findings must be charted on a growth chart. Before I end this segment, I will ask a few questions so that you can realize how much you have assimilated from this exhaustive discussion. You can write down the answers in the comments box below. Question 1. How to differentiate between iron deficiency anemia and thalassemia? Question 2. How to differentiate between iron deficiency anemia and anemia of chronic disease? I have already given the answers in the preceding discussions. Question 3. A pregnant patient has iron deficiency anemia that is confirmed by investigations. CBC reveals that she also has significant eosinophilia. What is the likely cause? One last question. What are the units used for measurement of hemoglobin and ferritin. Sometime later, I will post the answers to these questions in the comments box and I will pin them at the top. If you want to know more about this topic or any other topic in obstetrics and gynecology, please refer to my books Modern Gynecology, Modern Obstetrics, and Practical Obstetrics and Gynecology, and other books. For purchase inquiries, contact me on this WhatsApp number. I have also published 2 question-answer books which are particularly useful for exam going students. These are Clinical Cases in Obstetrics, 1000 plus questions and answers, and Clinical Cases in Gynecology, 1000 plus questions and answers. You can also follow me on other social media platforms like Facebook or Meta, Blogspot, and Instagram. The links are given here. If you enjoyed this video, hit the like button, share it with your friends, and also subscribe to my channel for more videos like this. Thank you for watching.